or cerebral amyloid angiopathy is a disease of older people where amyloid deposits in the vessel wall gets weakened, and you can have bleeding. But these are uncommon in younger patients. And so in young adults, we need to kind of expand our thinking and consider what we call a syndromic vasculopathy, which is what COL4A1 is. It's an inherited genetic cerebral small vessel disease category. So the other kind of systemic manifestations that tip us off to this are the eye and kidney abnormalities and family history, which can provide the clue to this being mutation and cause of small vessel disease on MRI. So, some of this was covered this morning, but it's really a disease of this type 4 collagen. So COL4A1A2 encodes chains that assemble into this heterotrimer, and the pathogenic variants lead to this abnormal collagen quantity or quality. The result is this fragility of the membrane within the brain, and you get blood vessel kind of dysfunction, impaired blood-brain barrier integrity, and small vessel. You get small vessel instability, and you get impaired small vessel stability. So this leads to both hemorrhage, as I said, kind of bleeding, and ischemia, which we kind of use, we call it white matter hyperintensity or lacunar damage. This is all kind of very much means the same thing. So what does this look like on imaging? So the neuroimaging signature is really a mixed small vessel disease. As I said, there's the question of bleeding and clotting. So the typical pattern, as you can see look at the flare to the left there, these confluent white matter hyperintensities, lacunes, where there's clearly damage deep within the brain. And then you can also have microbleeds. So if you look at the third one from the left on the top image there, the T2 SWI-GRE, you can see some of those black holes. Those are signs of bleeding. And they've been enlarged at the bottom to show exactly what those things look like when you kind of zoom in on them. Experimental models and clinical series suggest a predilection for lenticulostriate territory. So again, kind of deeper territories where the vessels have this right angle branch that creates extra stress on an already structurally weakened vessel wall from the disease itself. And then distribution often involves deep and subcortical white matter, basal ganglia, thalamus, brainstem, so all those, again, deep structures within the brain. So this mixed phenotype, the bleeding and the potential clotting or lacunar damage that we see in a younger individual is an imaging clue that really should trigger thinking about a genetic differential. Yeah. Multiple patients, yeah. So let's talk a little bit about the ischemic question here. So as I said, lacunar infarct, small, deep, progressive white matter injury. And as we saw in the MRI in the previous slide, there are these confluent white matter hyperintensities. A lot of this I'm repeating because I know it's very jargony, but I think you repeat it enough and it can sink in. And that way when you hear it again, you kind of know it triggers something. As again, symmetric, reflecting chronic small vessel insufficiency with demyelination and gliosis. So the contributing mechanisms to the ischemic phenotype include this kind of blood vessel wall dysfunction, this endothelial dysfunction, impaired reaction of the blood vessels because blood vessels react to higher pressures or lower pressures. The nature of the brain is very dynamic. So the blood pressure has to adjust within the brain, not just within the body itself. And so that reactivity is disrupted. And then we know that there are developmental lesions, schizencephaly and polymicrogyria, that reflect early fetal vascular injury, which a lot of my pediatric colleagues will probably talk about and know far more about than I do. Some of the consequences of these lesions may be focal epilepsy or seizures. And interestingly, migraine with aura is common in COL4A, and I think that probably has to do with the impaired vascular reactivity or function, because we know you take general population in patients without COL4A, migraine with aura is a risk factor for ischemic stroke. And so there is some relationship between migraine with aura and vascular dysfunction. And so I think that is probably why migraine with aura is more common in COL4A patients. Let's talk a little bit about the bleeding manifestations. So these abnormal basement membranes also cause vessel walls to be weak and fragile. Hemorrhage can occur in utero or a perinatal period, leading to cerebral palsy. It can also happen later in life. So patients can develop larger bleeds, macrobleeds, microbleeds, smaller bleeds, or trauma-associated hemorrhage. So high blood pressure, head trauma, and blood thinner or antithrombotic exposure can likely amplify this hemorrhagic risk, this risk of bleeding. So we have to think of this generally as there's this extra fragility in COL4A mutation that creates this hemodynamic stress that we have to be extra careful about or extra concerned about in the clinic. So when do we kind of think, if a patient hasn't had genetic testing, hasn't already been referred with a known diagnosis, when do we think that we need to test for COL4A? So young or middle-aged patient with small vessel disease, again, disproportionate to the conventional risk factors that we see in older patient population. If we see mixed clotting and bleeding signs on the MRI, if there's a perinatal stroke history and an early onset small vessel disease, again, small vessel diseases are those lacunar, subcortical, deep white matter injuries. And any of the above with eye or kidney or family history clues really should push us to test very early on. So I'll just give some illustrative examples from my own practice and patients that I've seen. And there's, I think, a lot that we can learn from patients. A lot of research questions come from seeing patients and come from patient questions. And so those are really important for us. So one of the things that is just interesting and I can't quite figure out is just the kind of range of presentations. So you can have perinatal injury and that can be followed by decades of radiographic stability, meaning the MRI just hasn't changed at all. There's been no further damage, which is strange. And there are examples of the same variant, meaning the same mutation, but very different phenotypes or very different presentations across relatives. And then I have a patient with sensorineural hearing loss, very young. Is this associated with Gould syndrome or something separate? And what do we do with patients who continue to accrue ischemic strokes but also have bleeds? Is there a way that we can help them? So here's first patient, young patient with a COL4A1 related disorder with, won't go through it's a mouthful, the variant, but not on aspirin. And the MRI has been stable for over 2 decades. Immediate relative with the same variant with no neurologic issues and no significant findings on MRI. So the contrast really is striking, but characteristic and sort of reflects this marked intrafamilial variable expressivity and incomplete penetrance in COL4A disease. This other patient that I have is a young woman with cataracts, microcephaly, hypoplasia of the posterior fossa, multiple intracranial aneurysms, and she has learning disability as well. And you can see that the top left image there, if you look sort of south on the page, there's almost no tissue there, and that is the hypoplasia of the posterior fossa. The top right, you can see, is an imaging example of an aneurysm that she has. The bottom right image, you can see that white, what we call like hyperintensity, this confluent white matter disease that she has. And then the bottom left is the image that typically shows hemorrhages. And you can see there's kind of one very small one, at least, on the, maybe I'll just point it out here, right here, at least, and then maybe one kind of below it too. So her genetic testing revealed both COL4A1 and COL4A2 mutations. The primary finding was the COL4A1, which was her pathogenic variant, and then COL4A2 was a variant of uncertain significance. And her mother and brother have the same mutation. So she became pregnant, had a son who has cataracts, and the son was found to have the same mutation and is being seen at CHOP, potentially by some of my colleagues here in this room. The family recently contracted the flu. This was this past winter. And I think it was hit them all pretty hard. While sick, the mother of the patient noticed that the patient had weakness in the right hand. With altered mental status, she was confused, she couldn't walk straight. And so they went to another hospital. An MRI was done. You can see the difference on this MRI from the one prior, I think. So there's new blood in the brain, and this bottom left one, you can see all these sites of bleeding. And there is some new ischemia too, so there were kind of mixed clots and blood as well, though maybe the ischemia this isn't the perfect slice of the image. And she's not been on aspirin. What I think probably happened is the physiologic stress of having influenza was probably sent her over the edge. Again, we're talking about fragility within the blood vessels of the brain and the brain itself. And so if there are changes, perhaps she's dehydrated from being sick, perhaps there are changes in blood pressure that affect the blood vessels, this leads to more stress within the cerebrovascular network and on the physiology. And so probably there was mixed both clotting and bleeding for her. She did have an EMG to see if there was some peripheral nerve problem, but that was negative, as we kind of expected it would be. The other thing that this sort of brings up with her symptoms is that she has had tinnitus for years, so ringing in one of her ears. And then she also developed this new left-sided sensory neural hearing loss over the last few months. She's going to see ENT, but it did bring up the question whether this new sensory neural hearing loss, given her age, is related to her mutation. So this is just me kind of, as I was thinking about her, why this happened to her. It's unlikely, but it's possible. I mean, typically for COL4A1, A2 mutations, sensory neural hearing loss is not part of this. But there is a relationship with other COL4A genes, and in particular, there's this isotype switch that occurs where initially this COL4A1A2 coded heterotrimer then is replaced by this other heterotrimer later on. And so it's theoretically possible that some of this fragility could contribute to auditory symptoms in some patients, or if it's related to this switch that happened. But I don't know, and I wonder if some other colleagues will have better insight. So we'll see, hopefully our ENT folks can help with her. So those are the patient presentations. So what does a workup look like when we see a patient with COL4A mutation? We get an MRI of the brain to look at whether there's damage already. We look at the blood vessels in the head and the neck. The neck is less, I think, mandatory, but we do often get it to look for aneurysms, because aneurysms are part of this disease. And then, of course, we look for any kind of labs and imaging that will help us tease out if there's ophthalmologic or kidney issues. And, of course, we involve genetics if they're not already involved. So what does a management framework look like from my perspective? There's no disease-specific therapy that exists yet. So management really is kind of monitoring and preventive. So the core jobs are reduce further brain injury, surveil for complications, and prevent avoidable harm. And for vascular neurologists, the hardest decisions are often about antithrombotics or blood thinners. It's very easy, we counsel lifestyle changes to reduce the risk of having another stroke, exercise, diet, cholesterol control, all those things. Those are things that they are medications, but they're easy for us to reach for because all it takes is a conversation. But the question for us about medication management becomes very difficult when we think about blood thinners. There's no evidence that supports the routine use of blood thinners for primary or even secondary prevention for patients with COL4A, because again, we're worried about the bleeding burden for patients. And the data for using acutely IV thrombolysis, which is a drug that can break up clots when a patient is actively having a stroke in the early window, again, is sort of not proven, and more likely than not should be avoided. Anything that increases the risk of bleeding really should make us pause. So what do we do about managing hemorrhagic risk? So aggressive blood pressure control is central. Avoiding head trauma, performing an MRI brain and MRA, looking at the blood vessels to see if there's aneurysm or further accumulation of hemorrhage. But the optimal interval, how often we should do these things, is uncertain. So where's the future for this in the stroke world? Well, there is some interesting data that's come out that may be promising for COL4A patients, at least in reducing the risk of the ischemic part of the strokes. So factor 11, which is involved in the kind of the clotting pathway, is involved in clot formation, but not really involved in bleeding so much. So the theory was that if you could inhibit this factor, you could prevent the formation of clot without increasing the risk of bleeding. So there's a recent trial that was published in New England Journal and presented at the stroke conference of this factor 11A inhibitor, asundexian, versus placebo. So they took patients who had just had a stroke, who were on some kind of antithrombotic therapy, maybe it was aspirin, maybe it was Plavix, maybe aspirin and Plavix. And on top of their antiplatelet therapy, they added this drug or a placebo. And it was very clear the asundexian arm overwhelmingly reduced the risk of recurrent ischemic stroke without actually increasing bleeding. And we can look at these charts here. So if the top one is the event rate of ischemic strokes or clotting strokes. And you can see that over time, patients with placebo had far more ischemic strokes than the asundexian arm. And it was both clinically and statistically significant. More importantly, for our purposes, is the question of major bleeding. So there was no difference between the arms in terms of major bleeding, which doesn't necessarily prove that this drug does not increase the risk of bleeding, but it makes that a possibility. And so I do wonder if there's some future here for using this for COL4A patients who have ischemic stroke or at risk of ischemic stroke, in addition to many other areas. Sorry, were you about to?
Can you address NSAIDs?
Yeah, so the NSAID thing, I think if you're being very, very cautious, it's not something that you would take. You just be careful about that. But, I think I tell patients in a rare circumstance they really need good pain control and Tylenol just won't cut it. They can take an ibuprofen. But I would say if you're being very cautious, probably shouldn't. Yeah.
If you have a question, can we use that microphone and hold questions towards the end? Yeah.
Oh, sorry, that was my fault. I said, yeah. I'll be done very soon. So this is kind of the simple workflow that we have, which is you recognize that there's something kind of atypical going on here. To phenotype things, to not just get a sense of the genetics, but get a sense of, on the spectrum of mild or nothing to severe, what is going on with the patient in front of you. And to do that, you not only have to get a history, but you have to look at imaging, you have to look at vessel imaging, and you have to kind of get a sense of the kidney function and the eye function, things like that. And ultimately, it leads to a question of management, which is really risk factor optimization. It's so important in COL4A to have a healthy lifestyle and to manage, blood pressure and diabetes and cholesterol. Those are key. And then the factor 11A inhibitor is a question mark. Certainly not ready for any kind of prime time or experimentation necessarily, but just food for thought. So take-home messages, we're thinking about COL4A1 too when the MRI is discordant with the clinical history or the age of the patient. Genotyping helps, but phenotype and family context drive real-world counseling and management. Regular visits and imaging for monitoring, and the question about factor 11A. and so I just want to thank everyone here for inviting me, and thanks to the Gould Syndrome Foundation, to my mentee, Dr. Alton, who's one of our NIH research fellows, and I'm happy to take any questions anyone has.
Hi. In terms of damage to the brain for bleeding versus clotting, is one more, does one damage more than the other? Are they kind of equal? Can you speak to that?
Yeah, it's a great question. I think you're more likely to see bleeding, but the extent of the damage, I don't know that we've necessarily characterized whether one is more than the other, if that makes sense. Meaning you can have a clot that affects, this much area and a bleed that affects this much area, and unclear whether one actually does more damage necessarily than the other, if that's what your question was getting at.
Yeah, so it's more dependent on the size and the area of the brain.
Exactly.
Versus the bleeding or. Yeah.
We're using this so people online can also hear the questions as well, so that's why. I do have a question from an online. Can patients, this is strictly for adults, can patients present with cognitive impairment even with mild SVD findings on MRI?
I don't know. I think I think we haven't characterized this well enough yet in adult patients. I would, if I'm just sort of thinking out loud here and going through this, I would expect if there were cognitive impairment, it would be from the small vessel disease, the accumulation of this damage to the brain from small vessel disease. But COL4A patients are human beings just like everyone else, and we're all at risk of other things happening. And so I don't know if necessarily it would be the COL4A would be the culprit in that circumstance.
A few slides back, there was mention. A few slides back, you mentioned the switching from the 1 and 2 to the 3, 4, 5.
Yeah.
Could you speak to that a little more?
Yeah, so I don't know much about this. This was just sort of when I was trying to figure out what was going on with her, I was kind of reading through, but I think that happens very early on where that switch happens. So I think my, I guess probably misplaced hypothesis, because it's not my area of expertise, would be that maybe during that switch there was some abnormality or some residual collagen that was encoded by COL4A1A2, and that led to this increased risk of hearing loss. But I don't know if that's true. I was trying to think out loud, I guess.
Oh yeah, I could speak to that a little bit.
Yeah.
So, again, thinking evolutionarily, that collagen for alpha 1 and collagen for alpha 2 are the primordial network, and then later along came this alpha 3, 4, 5 network, and so it's very well characterized in the kidney, the glomerular basement membrane. Right, we talked about Alport syndrome a little bit, is caused by pathogenic variants in alpha 3, alpha 4, and alpha 5. But during development of the glomerular basement membrane, it's the 1-1-2 network, and then it gets moved away and it's replaced by 3, 4, 5. And so it's a very developmentally regulated process, and presumably the same thing that's going on in the cochlea. We've seen in mice, if we do electron microscopy of the glomerular basement membrane, there are defects. So even though the collagen for alpha 1 and alpha 2 network have disappeared and been replaced by the 3, 4, 5 network, there are residual defects in the GBM. And so it's certainly plausible that what you're suggesting is true.
Have you seen it in any human patients that you've had?
Nope.
No. Okay.
No. I haven't looked.
Hi, I had a question, I think, along the same line, talking about the brain damage. Is there, like, as far as you know, like a correlation on the a study that shows some sort of correlation on the site and the extension and the type of brain damage. I was thinking also the type of epilepsy. I mean, because I was searching for this information because I'm modeling this, and I wonder whether any of you is aware of a study and whether it would make sense to have this kind of information.
Yeah, this is something I'm interested in ischemic stroke, looking at how strokes affect particular networks within the brain and whether that increases the risk of certain deficits. That study for me is still ongoing, so I don't know yet. but my hypothesis is that yes, that you can have the same size lesion in one location or another that doesn't cause any clear physical abnormalities. It's not in a motor pathway necessarily, but it affects a neural network, and that's where you get into trouble.
Comment on that a little bit too. So again, in mice, we work in mice. There's a distinction. There's an interesting age-dependent influence on where the hemorrhages are. So, like in a newborn pup, say up to the first week, the hemorrhages are small and throughout the whole brain. So it's looks like little stars in the sky, and they're everywhere. And then by like 1 month of age, which would be sort of a juvenile or early young adult, they basically disappear, and the cortical hemorrhages are cleaned up. And then once you get into like 6 to 8 months of age, you have fewer but larger hemorrhages, and they're usually in the basal ganglia. So you no longer get cortical hemorrhages. And we think that that's representing like a switch in the underlying mechanism, in that at birth, all the vessels are just kind of fragile, and so anybody can rupture. But then with age, it tends to be in these vessels that they just can't regulate the pressure well enough, and the blood vessels that feed the basal ganglia branch at sharp angles and go through fewer steps of like pressure reduction. So they're like more sensitive to fluctuations in blood pressure. Yeah.
So you mentioned that early on the pups have like scattered like damage, and then it goes away. Is that related to like neuroplasticity, do you think? And healing? Or you don't know? Okay, I'm just curious.
I'm sorry. We have a lot of questions. We also have questions online that we may direct to Dr. Rothstein later, and I can give you a way that you can do that. But we do have to continue on. I'm so sorry.